Hi, this is Dr. Barry DeZamba. This is week 2, and we're going to talk about the point of care technology. To review from last module, the Office of the National Coordinator, this information can be seen by going to healthit.gov. This is the Office of the National Coordinator for Health Information Technology, otherwise known as the ONC. This is at the forefront of the administration's health IT efforts and is a resource to the entire health system to support the adoption of health information technology and the promotion of nationwide standards-based health information exchange to improve healthcare. The ONC is organizationally located within the Office of the Secretary for the U.S. Department of Health and Human Services, also known as HHS. The position of the National Coordinator was created in 2004 through an executive order and legislatively mandated in the Health Information Technology for Economic and Clinical Health Act, otherwise known as the HITECH Act of 2009. Through its work, the ONC remains focused on two strategic objectives. One is advancing the development and use of health IT capabilities, and two is establishing expectations for data sharing. As of May 2018, there are statements of organization, functions, and delegations of authority from the Office of the National Coordinator for Health Information Technology. If you wish to click on any of the links, the non-audio version of this slide deck can be found in the reading section in Canvas for this module. There is a 2020 to 2025 Federal Health IT Strategic Plan. The U.S. Department of Health and Human Services published this plan. The plan outlines the federal health IT goals and objectives with a focus on individuals' access to their own electronic health information. And again, you can go to the non-audio version of the PowerPoint slides in Canvas and click on the link, or you could simply Google the healthit.gov website and find it from there. The plan was developed by the ONC in collaboration with more than 25 federal organizations and informed by nearly 100 public comment submissions. The plan demonstrates the federal government's ongoing coordinated focus on improving the access, exchange, and use of electronic health information. Specifically, the plan explains how the federal government intends to use health IT to promote health and wellness, enhance the delivery and experience of care, build a secure, data-driven ecosystem to accelerate research and innovation, and I will add in there, in addition to research innovation, also for public health and surveillance, and to connect healthcare with health data. Some key health information technology terms. EMR is an electronic record of health-related information that can be created, gathered, managed, and consulted by authorized clinicians and staff within one healthcare organization. Many times we use the term EMR and EHR interchangeably, but the definition of an EHR is very similar. It's an electronic record of health-related information on an individual that conforms to nationally recognized interoperability standards and that can be created, managed, and consulted by authorized clinicians or other healthcare providers and staff across more than one healthcare organization. A PHR is an electronic record of health-related information on an individual that conforms to nationally recognized interoperability standards and that can be drawn from multiple sources while being managed, shared, and controlled by the individual or the patient. Electronic health record adoption refers to how well the staff and users actually use and embrace the system as part of their routine daily activities through their workflow, their clinical workflow, and their administrative workflow. Innovativeness, socially constructed process that is aligned with an individual's willingness to change what is familiar. So if we talk about EHR adoption, we can use standard innovation theories, such as looking at innovators, early adopters, the early and late majority, and the laggards. The innovators. These account typically for 2.5% of the population of an organization. Innovators seek to help define the system, embrace and understand the technology. Typically, these are the techie colleagues around us, but this is not just IT, and many times you'll see IT folks, employees in the organization that actually are not the innovators. The innovators push for advanced functionality of the system, pushing limits, creatively thinking of ways to improve the system. Early adopters. Early adopters represent typically 13.5% of an organization's population. These are often people that are considered super users of existing systems or champions. They are supportive in the system and realistic in the approach of the system. The early and late majority. This represents the bulk of staff, usually 68%. They understand the need to use the system. In general, they use a portion of the system, but need to adopt or learn to other aspects of the system. They often use workarounds in an effort to not use the system more than they absolutely have to. And then we have the laggards. These are the final 16% of people. They are the most resistant to use anything new, whether it's technology or new processes, many times very resistant to change in an organization. Many times these same people will cite a concern that this new technology could impact patient safety or that they plan to switch jobs. They really need a lot of support and hand-holding. Once they adopt the new technology and they become familiar with it, they do eventually become supportive. Systems development life cycles. The acronym for this is SDLC. We use this term a lot in IT and engineering. When considering evaluating an EHR, excuse me, always consider who the end user is going to be. Also, end users should be involved in the process. All of the stakeholders should be involved in the process, from clinicians being involved in the design of the system, testing it, training, implementation, and ongoing support and optimization. They should be involved in governance committees for data and infrastructure and everything related to the EHR. Satisfaction of end users. There's a validated survey known as the Clinician Information System Implementation Evaluation Scale, and that PDF is listed in Canvas. Return on investment. I will say in my experience, I have been told when I was at Penn State Health and Penn State College of Medicine, at that time it was about $100 million to move from the existing Cerner EHR implementation and move to Epic. A return on investment includes the estimated total costs for the implementation and adoption of an EHR, and this is a primary concern for providers and hospitals. It's not just like purchasing a subscription of software or purchasing, a CD that has Microsoft Office on it for X number of dollars. The total costs or the total cost of ownership includes hardware, so making sure there's the necessary servers, computers, cabling, network cards, everything related to network, as well as the actual software itself. And that actual software can be more than just the EHR. It could also be business intelligence or analytics software to be able to run reports. It could be additional servers for reporting, additional servers for having a research database, and so on. It could include implementation costs. So that would be actual human resource labor. So all of your IT people, and possibly paying overtime or shift differentials for clinical and administrative staff to come in at night or on the weekends to do testing. And end user costs, because not all of the end users are going to be, or they're not going to remain the same level of productivity in the beginning of the use. Why do organizations replace their EHR? Well, it could be the vendor goes out of business, a new vendor emerges with a superior product, there could be a serious problem with the current EHR, care or business model shift, enough that you need a new product. But I will say that everybody here has access to the Gartner, Gartner gateway on the Temple University TU portal. Gartner is a software agnostic research firm. They do a lot of work in researching electronic health record vendors. And so that is the best place to go. And that's where CEOs and CIOs and executive leaders in healthcare will go to look at not just the top name of a software vendor, but everything you need to know about implementing or replacing an electronic health record. Because it's not just reaching out to a top name like Cerner or Epic, it's actually looking at the data architecture, the data model. There are a lot of technical considerations, and a lot of it depends on the type of healthcare delivery system. An academic medical center is much different than a community hospital. There is an electronic medical record adoption model called MRAM. HIMSS, which is the National Organization for Health Information Systems. The HIMSS electronic medical record adoption model, MRAM, measures clinical outcomes, patient engagement, and clinician use of EMR technology to strengthen organizational performance and health outcomes across patient populations. Measuring evidence-based data at each stage, organizations use MRAM to optimize digital work environments, improve performance and financial sustainability, build a sustainable workforce, and support an exceptional patient experience. Again, if you want to go out to the HIMSS site, you can go right out to HIMSS.org, or you can go into the no audio version of this slide deck in Canvas and click on the links. And there are some other documents within the Canvas modules. Measures of success. Well, EHRs need to be useful, feasible, ethical, and accurate. The 21st Century Cures Act, this was passed by Congress in December of 2016. This act is largely known for its focus on the FDA and Precision Medicine Initiative. But the 21st Cures Act also has some provisions related to Health Information Exchange, otherwise known as HIE. HIEs define interoperability related to HIT. You can go out to the FDA.gov regulatory information to learn more and also view the attached articles in the Canvas module. The Public Health Information Network, PHIN, originally aimed at connecting labs, event detection, outbreak management, partner communication, and alerting. In 2010, released the Cascading Alert Checklist. 2013, the S&I framework added the Public Health Reporting Initiative, PHRI. I will also say that in recent years, public health information, it has really started coming from various surveillance methods. Right now, Temple University has a 5-year, $9 million grant with the Centers for Disease Control to look at long COVID, both as a passive method, looking at data in the Temple University Health System electronic health record, and that's part of a passive protocol, but also doing an active surveillance protocol, finding patients that have documented cases of COVID-19, reaching out to them through surveys and collecting information to determine the prevalence of long COVID. Then we have technology and data standards. If you are ever interested in really digging into data standards, there is a course here in the Health Services Administration and Policy Department in the Health Information Management and Health Informatics programs. It's HIM 5128, typically offered in the spring. So some of these standards for healthcare include HL7, this is for clinical data, X12N for financial and HIPAA mandated transactions, DICOM for images. We also have NCPDP for pharmacy business functions, IEEE for bedside instruments. Then there's terminology standards. Sometimes we refer to these as controlled vocabularies or ontologies. There's LOINC for lab data. For drugs, there's RX norm, NDFRT. There's also MOLTUM. Billing, there is CPT for procedures, ICD for diagnoses and conditions. For clinical, there's also UMLS, SNOMED, and others. Also with data standards, there's HL7 to be able to get data into the EHR, codes such as ICD-10 and CPT codes, very useful for extracting data out, large amounts of data, especially for surveillance, population health, and research. One aspect of meaningful use is still lagging, and that's the need for care coordination. There's also a data mapping process of linking interoperable components from one system to another system, associating concepts or terms from one coding system to concepts in another coding system. And there are some large-scale networks that do this well with de-identified or limited data sets. One is right within Epic, which is Cosmos, COSMOS, and we'll have a demo later this semester. Another is TriNetX, TRINETX. And controlled medical vocabulary. We also have content, concept orientation, performance, identifiers, and all of these other characteristics here with the appropriate descriptions. Please take a look at Canvas. If you have any questions about this week's readings or assignments, please reach out to me through email via Canvas, and we will see each other at our next Zoom call. Thank you.